Well, there we go. That was fun. I just recorded one whole section of a lecture not realizing that I actually wasn't recording. So that's okay. I've got the information down pat now. We're going to be finishing off Learning Plan 7. We're going to talk about one topic fairly briefly and another topic at quite more length. Well, that's a good thing I don't teach English. SBAR communication. It is pretty much the standard in nursing now. There are other forms of communication, written communication using DAR, data action response, or SOAP, subjective objective assessment and plan. But we're going to use SBAR, situation, background, assessment, and recommendation. I recommend not recommending unless you are a seasoned nurse with experience and you know the doctor you're working with. Some doctors will not take recommendations from nurses. I know a couple. Many doctors will when you've demonstrated that you know what you're talking about. But that takes a little while. New grads have not demonstrated that they know what they're talking about yet. I'm sorry to say that, but that's the case. When you get out of school and you pass your boards and you are a new RN, you are still learning. And you will be learning for a couple of years. So as a new grad, I don't want you really recommending anything to a doctor unless the doctor says, what do you think? Then you can give your recommendation. I like to use the word request for the R. Situation, who is your patient? Background, why are they there? Assessment, what's going on? R, here's the easiest way to finish that SBAR communication. The R is, what should we do about this condition, doctor? See, when you do that, you make it very clear what you're asking the doctor for and why you're asking. You're addressing one problem, not everything, and you want an answer to that one problem. Let's take for example, we have Mary. Mary's an 80-year-old woman admitted again with congestive heart failure. She's been in the hospital about every other month for exacerbations of CHF. At home, she really doesn't follow a diet good. She likes her ham. She likes her potato chips. She just doesn't follow a good low-sodium diet. So about every other month, she comes in and she's all puffy. So you have her in the hospital. She's been started on her diuretics and she's diuresing. And you come in the next day and you notice that she's puffy again. She's got 3+ edema in her lower extremities. So that's not supposed to be there, right? She's taking Lasix, furosemide, 40 milligrams BID. That should be working. So what are you going to assess? Well, you're going to assess her vital signs. You're going to assess her level of consciousness, her skin turgor, her urine output. You're going to do a focused assessment on kidney functions, basically. You're going to look to see, is she putting out fluids? And if she isn't, what's happening? Well, in this case, she's probably third spacing in her legs. So you're going to go to the doctor. The doctor, you're going to give a good SBAR communication. Situation. Doctor, we have Mary. She's an 80-year-old patient who's recurrent CHF exacerbations. Situation. Background. She doesn't follow her diet very well, so she frequently comes in about every other month with exacerbations. We've been treating her with BID Lasix, 40 milligrams, orally, and so that's her background. And her vital signs are this, this, and this. Her skin turgor suggests this, and she has 3+ pitting edema. So you've given your background and your assessment. They kind of blur together. Now you say, what should we do about this edema, doctor? Boom. You've done your job. You can give that SBAR report in less than a minute. You probably can do it in about 30 seconds. And that's good because the doctor usually gives you about 30 seconds before they just tone you out. That's really the truth. 15 to 30 seconds is all a doctor is going to give of their attention. They are that much in demand. That's in general. Of course, there are doctors that are different. So, situation background assessment, and what should we do about this doctor? Now, the doctor might say, what would you like to do, nurse? Then, go ahead and say, how about we try 20 milligrams of IV Lasix right now? Or you could simply say, I'm not sure, doctor. That's valid too. But if the doctor doesn't say, what do you think we should do? Just say, how should we handle this edema, doctor? You've specifically asked a question. A specific problem has been presented to him, and in your documentation, you will document it exactly that way, that you gave the situation, the background, the assessment, and you've requested the edema to be addressed. You'll document that so that there is evidence that you saw the problem, you realized it's a problem, you've assessed it as a problem, and you've requested a resolution of the problem. If the doctor says, I'm not worried about it, let's just check it out for another day, you'll document that. If the edema gets worse, guess what? It's not your fault. It's the doctor's fault. Most doctors will give you some sort of order to treat that, but you never know how each doctor is going to work. SBAR communication. Very important so that everybody's on the same page. There's very clear communication, very concise, yet complete. Again, there is not a lot of excess time in hospitals. You need to be complete, yet brief. Get the information out. Don't go into her extensive background and why she developed congestive heart failure, because she had a heart attack 20 years ago, and she's got this and that, and unimportant. Unimportant. You don't have to give multiple days of vital signs unless the vital signs are trending a change. Be complete, yet brief. And that is a skill that students have a difficult time with. That's a skill that a lot of nurses have a difficult time with. I sometimes have a difficult time with it. So how do we do that? How are we going to make sure that we are complete yet brief? What do you think? Simple thing is, write it down. Grab a piece of paper and write down S and put your situation. Your B, put the background. A, the assessment, and R, what do you want done? Write it out. Script it. Script it. Read the script to yourself so that when you talk to the doctor, you can have it flow out naturally. So that's preparation and organization, isn't it? Part of this class. You want to be prepared when you talk to the doctors. You want to look like you know exactly what you're doing, that there's no question of what's going on. When we communicate this way, we sound logical, we sound organized, we sound competent, and we are logical, organized, and competent. That's very important. Use SBAR communication between shifts. It makes the shift report go much faster because you're going to hit the important things and you're going to skip the trivial. Believe it or not, there's a lot of trivial stuff in a hospital that goes on. For the life of me, I can't think of something right now. But when you get me for advanced clinical and at Holy Family in Manitowoc, I'll point out trivial bits in reports, and then it will make more sense. So SBAR communication, critically important that you use it all the time when you write things down, when you talk, when you give report to doctors or other staff members or anybody. It makes sure that you cover everything that has to be covered without a lot of extraneous details. I do want to do a quick sidebar now. Those of you that from LTC that may be with me for advanced clinical at Holy Family in Manitowoc. I'm not sure who it could be. I don't really remember all the names. But those of you that are with me, we will have a unique situation. One of the surgeons on the floor is Dr. SBAR, and it's spelled S-B-A-R. Do not go up to him and say, Dr. SBAR, here's what I have to tell you. His name is SBAR. He is an incredibly nice guy. He really is. He's a good teacher. He's easy to approach. He explains what he's doing. But his name is pronounced SBAR. So is his wife's name, SBAR. Very unlikely anybody else in the state will ever encounter that situation. But I just wanted to mention that. So that is SBAR communication. I honestly believe that it probably doesn't need to be discussed in greater detail. I think we've got that covered. I hope we have that covered. I hope you've been practicing SBAR communication all along, that this is just kind of like a reminder. But I want to spend more time on conflict management. Conflict management is a nonstop problem. You will never work a day in your life without having some form of conflict. Could be with a coworker, a physician, a family member, a patient. You handle them all differently, yet the same. What do I mean by that? Well, if you're talking to a doctor or a family member, you're going to use different words and different reasonings, but you're still going to address everybody directly. If you have a problem with somebody, you talk to that person first. If one of you students has a problem with me, talk to me first. Tell me what the problem is. I might not know that you're having a problem with something I'm doing. If that happens, I'll do something and a student will be unpleased, displeased, I think is the proper word. But they don't say anything. They smile, they nod. Inside, they're angry, but they're giving me this body language. How am I supposed to know? So if you have a problem, go directly to that person. If the problem is not resolved, then what? Now you go to the person above them. If you have a problem with me, going to your peer students is not going to solve the problem. Going to another instructor is not going to solve the problem, because they're going to tell you exactly what I tell you when somebody complains to me about somebody. Go talk to them. I'll listen, but I'm not going to solve any problems for you. It's the same thing with any other instructor. So that applies in any school, anywhere. So there are different types of conflicts that are factors that lead to conflict. There could be a role conflict. When two people have similar responsibilities but have ambiguous boundaries. Where is that? I'll tell you when that is most common. And let's write this down, because this is some important things. Role conflict. Similar job and fuzzy boundaries. Similar job with fuzzy boundaries. Where can that happen? Change of shift in the hospital. Holy Family has a change of shift at 2 in the afternoon from day to PM. So what happens when a doctor prescribes a medication to be hung at 2 o'clock? Is it day shift or PM shift? Medication, you have that, if medication is scheduled for 2 p.m., also known as 1400, right? It can be given as far as 3 p.m. or as early as 1 p.m. But it's scheduled for 2. Why is that a conflict? Because the day shift works 6 to 2, and the PM shift works 2 to 10. Who gives it? Role conflict. Classic role conflict. How can we resolve that? How can we resolve that conflict? Just have a unit meeting and discuss it and make a unit decision. Do the off-going nurses give it or the oncoming nurses? Ideally, you have the doctors programmed to not order medications be given directly at change of shift. That'll be the best thing. Won't always happen, but that is how you handle it. Now, again, that's a problem between shifts, so you have to have the 2 shifts talk. And you're going to have PM and night shifts talks, and night shift and day shift are going to have to agree too, because there's going to be that same conflict everywhere. How about another role conflict? You have a patient in the hospital. You have a hospitalist on case. You have a surgeon. You have a cardiologist. Oh, unless a psychiatrist in for good measure. And the hospitalist that admitted the person, it's their day off, so they have a new hospitalist coming in. The surgeon and the cardiologist are on vacation, so they have other people covering for them, and the psychiatrist is only there for psychological problems. Problem comes up, who's going to deal with it? That's a role conflict that's out of your hands, but has to be resolved. So role conflict, major problem. And again, it's between similar people with similar jobs, but have boundaries that overlap one another. How about a communication conflict? Well, how do we prevent communication conflict? Simply using SBAR communications. But a communication conflict. Conflict. It's when you just don't talk about the problems. When that student has a problem with me and they don't talk to me, simply no communication is the source of this conflict. You're failing to communicate. It automatically creates a conflict. There's a problem. You think there's a problem. I have no clue that there's a problem. You're not telling me about the problem. You're telling someone else about the problem, but they can't help you. I'm clueless until somebody gives me a hint that, hey, there's a problem. Communication conflict. Very common. And we talked about this earlier. The mice personality will do that, right? And because they don't want to say nothing. And we're going to talk a little bit later about other personality types that will act in that way. How about a goal conflict? A goal conflict. Well, that happens in nursing when one nurse wants to promote their personal achievements over other people. So, suppose you have a group of nurses working, and one nurse decides to go back to school for her master's or his master's. That can be totally innocent and harmless, or it can create a lot of conflict if that person assumes that because they have new initials after their name, they are better. And let me tell you, initials after a name do not necessarily make anybody better at their job. It can. It certainly can. But there's no guarantee of that. So that's a goal conflict. Another goal conflict. You have two doctors on the case. And one's a medical doctor, one's a surgeon. And they have different points of view. That's a goal conflict that is all too frequent. By the way, in general, who takes priority when you have a medical doctor and a surgical doctor? Who takes priority? Usually the surgeon. But as with all usuallys, there are exceptions. And a lot of times the surgeons will say, if something happens, if this happens, talk to the medical doctor. That's nice when that kind of cooperation and coordination happens. Doesn't always happen. What other kind of conflicts? How about a really challenging one? Personality conflict. Oh my gosh. Have you ever been a part of a personality conflict? If you say no, well, I'm going to assume that you don't even realize what a personality conflict is. Everybody has personality conflict because nobody gets along with everybody. I don't get along with everybody. I try to, but it's human nature for some people to get under your skin and right? Maybe I'm doing it to you right now. Sorry. Personality conflict, can't we all just get along? No, we really can't. We're humans. We all have different needs, different plans, different viewpoints. So how do we deal with personality conflict? How do you deal with that coworker that you just don't like? How do you deal with that student who sits next to you and you don't like? Or the instructor? A sibling? How do you deal with people you don't like? The best way is to treat them properly, politely, and then move on. You don't have to like everybody you work with. You don't. When I take a job, I'm not taking a job so I can make new friends. I'm taking a job because I want that job. Now, as it happens, I like the people I work with. It's really nice. I've had jobs, though, where I did not like some of the people I worked with. I still worked. I still went in, punched the clock, took care of patients, did everything I needed to do, and on the days that I had to deal with a couple of people, and it was 3 people actually. There we go, 3. There were three other nurses I didn't like working with. On the days I had to work with them, just shrug my shoulders and do my job. Do the best of my ability. Interact with them as little as possible. It's impossible to have no interaction, but you don't have to go out of your way to interact with them. And move on. Now, maybe it's something you're doing. Have you ever thought about that? It could be. You might be the source of personality conflict if you're the person who doesn't work as fast as everyone else, or who thinks the rules don't apply to them. They can do what they want. What kind of person is that? Come on. Oh, we talked about it earlier in this lesson plan. I'm going to let you figure that one out. You might be the person, or someone, maybe not you, someone might be the person who just never stops talking. They talk, and then they talk some more, and then they tell a joke and they laugh at their own punchlines. They talk. Remember that motor mouth? Yeah. All those things can cause personality conflict. Sometimes conflict can't be permanently resolved. It can be managed, though. And that's what we're talking about here. The last type of conflict is probably the most personal. Ethical or values conflict. And that's very easy to see in a hospital setting. If a nurse, and you will encounter the nurses who believe that life should be extended as long as possible, and you'll have nurses that believe that life should be spent as good as possible, but not necessarily as long as possible. Now that choice is up to who? It's up to the patient. Correct. But nurses can educate, and sometimes you'll have nurses educating on opposite sides. And that's a value conflict. It's an ethical conflict. There is probably no resolution to that. A person who believes that life should be extended to as long as possible will probably never be convinced that sometimes a shorter and better life is better than a longer, more miserable life. Sometimes, but not necessarily always. Let me give you a ethical conflict in my personal life. I've always been listed as an organ donor, always. Because I kind of feel, if I'm dead, I don't care. If somebody else can use one of my kidneys or my liver, my heart, whatever, take them. I don't need them. I'm done using them. My personal belief. Many people don't believe that way. My wife did not believe that way. I told her specifically, I've got the sticker on my license. If something happens to me, go ahead and donate things. She goes, I'm not gonna. I don't want them taking any pieces of you. Like, I'm dead at that point because, you have to be dead before they actually harvest organs. I'm dead, so you can do what you want. I will try to haunt you, but there's no guarantees that'll work. She would not budge. And that's okay. That's her value. And that is what is important to her. I'm not going to divorce her because she's not going to donate my organs. But back in 2000, her father got a heart transplant from an organ donor. And then later, her brother got a bone marrow transplant because he had leukemia. Suddenly, she was in favor of organ donation. And she put the sticker on her cards. Both my sons are listed in the organ donor records too. So sometimes values can change based on personal experience. I could never convince my wife verbally why it's important until she experienced why it's important. Ethical conflicts, sometimes you might get hired in a hospital that performs abortions. They're out there. If you are a firm, staunch, anti-abortion person, you probably shouldn't work at that hospital, because that's automatically causing an ethical and value conflict within you. And it's a conflict that you're going to lose, because you aren't going to be able to change the hospital's mind, and the hospital is not going to change your mind. So that's where researching your potential employers is important. You need to know what could happen where you're working. Now, what about conflicts with patients and their families? Okay, so by the way, did everybody get that now? 5 basically, there's role conflict, where there's 2 people with similar roles that have ambiguous boundaries. Communication conflict is just simply lack of communication. Goal conflict, where one person puts their needs above everybody else's. Personality conflict, where they just, personalities don't match. And ethical conflicts, where someone's values are contradicted by someone else's. What about families and patients, though? Are you ever going to have a conflict with them? Sure, of course. And it'll generally be one of those other 5. Could be ethical value conflict, where family wants to pull the plug, so to speak, and you think that's wrong. Could be personality conflict. All those conflicts apply to your interaction with patients and families. So how can we help prevent that? Quality of care. Make sure that we're always giving high quality of care. Try to exceed the bare minimum. We always say check in on your patients at least once an hour. Well, that's good. That's the minimum. But if you can pop in just briefly every half hour, if for no other reason, say, hey, I just want to let you know I'll be back in 30 minutes. Is there anything you need right now? Okay, good. I'll be back in 30. It's all it takes. That prevents communication conflict. It improves quality of care because they know you're checking on them all the time. Gives you a chance to solve a problem before it becomes a problem. Treatment decisions. Treatment decisions, big deal. Physician might want to do treatments that the family doesn't agree with. Now, the patient might want that. And as long as the patient is still his own decider, meaning they are still their own person, the patient's decisions take priority. Doesn't matter what the family wants. And that can cause more problems within the family. And of course, that always spills over onto us, because everybody wants us to take their side. And you may have experienced that in your jobs. So treatment decisions. It's really important, if possible, that you be in that room when the doctor talks treatment options. Because if the doctor's communicating up here and the patient's communicating at this level, you need to make sure that the patients understand what's going on. Family involvement. I can't spell anymore. Family involvement. The families need to feel significant. They do. And that's important. Have you ever been in a situation where you feel like you are useless? Like you cannot contribute anything? We all have. Find a way to get families involved. And it can be really simple. Suppose the patient is hungry for something and the hospital doesn't stock it. Maybe ask a family member if they can bring in a favorite food. Suppose the patient wants a beer or a shot of whiskey. Now, most hospitals are not going to have that to be able to provide that. As long as there are no absolute contraindications for that, and especially if the person is in hospice, why not? So send a family member. Make that family member the official bartender. Have the family give the patient a back rub. Just a back rub. Or read to the patient. Now, a lot of times family members will do that automatically, but if you ask them, if you say, could you do me a really large favor? I would love to be able to do this, but I'm tied up with other patients' needs right now who don't have family members with them. Could you give your loved ones a back rub for 10 minutes? I'll be right back. Gets them involved. Helps them take ownership of what's going on. Quality of parental care. Quality of parental care. We need to sometimes model correct parenting techniques, especially to new parents who've never been a parent before. And some of you may know what that's like. Some of you may not yet. But you will at some point probably. We need to model proper parenting techniques. We teach. Nurses teach all the time. So we need to demonstrate how to do this properly. Let me give you a for example. I was working in the ER, and we had a call from the rescue squad saying they're bringing in a mother and child with hazardous chemical exposure. Okay, so they brought him in. We're all ready to go in our hazmat materials. It turns out the mom of the child and the grandma of the child had a fight. Mother was holding the 3-year-old. Grandma was angry. Grandma grabbed a can of lighter fluid and sprayed lighter fluid on mom and baby. As the police arrived, Grandma was reaching for a lighter. Now, it didn't go any further than that. But Grandma had had marks on her face because Mom had punched Grandma. So Mom came in handcuffs, baby came in. We had to take care of them, get them all cleaned up. They were healthy and fine. But the child, for lack of a better word, was filthy. His hair was just matted. And not with just lighter fluid, but with dirt and food, and it was just matted in there. And I asked the mom, when was the last time you showered the child's hair? She said, he won't let me. What? No, he won't let me. He won't let me wash his hair at all. Well, does anybody wash his hair? No, he won't let anybody wash his hair. I said, no disrespect intended, Mom, but he's not in charge. That would be you. You're in charge. Well, I don't know how you do that. I said, well, let me show you. And I picked him up, and I got the water running at the proper temperature, and I stuck his head under the sink, and I washed his hair. She went, oh, never thought of that. Okay, so that's quality of parental care was a problem there. But we have to always demonstrate to everybody around us proper techniques, not just with parents and children, but with people and patients and their parents. We just have to demonstrate proper attitudes and techniques at all times. And the last one, staff inconsistencies. Staff inconsistencies. It's a big deal. We want to always make sure that every nurse that walks in is going to provide the same care with the same standards and the same decision-making ideas. Doesn't always happen, but that's the goal. No matter who walks in to take care of that patient, they get the same level of care. That'd be a wonderful world. But in fact, we get people that every nurse has a slightly different approach to a problem, slightly different response to a problem. is the more we can get consistent, the better the patient feels, the more safe the patient feels. This is where I really come down on pronouncing medications properly. If you mispronounce common medications and everybody else gets it right, and you come in and can't pronounce it, what does that say about you or the hospital? Or may confuse the patient. The patient may think, I've never gotten this medication before. So I'm not, those of you that may have me as a student, I'm not trying to freak you out right now about mispronouncing metoprolol, but that's a key one. Metoprolol tends to trip up a lot of people. So practice saying metoprolol. Staff inconsistencies is a major source of patient confusion. We're at 35 minutes now. I'm going to stop here. I guess I thought we could get all this lecture done in one segment. We can't. So I'm going to stop right here. We're going to finish off on how to resolve conflicts specifically, and the 5 specific conflict resolution types. And the 5 specific concept resolution types are really important to understand on how to work with people. So that's what we're going to do next.